Good afternoon. We're going to get started, so if people would take their seats, that would be great. I'm Judy Wasserheit, a former chair of the board of the Consortium of Universities for Global Health. And before this next plenary, I have the wonderful pleasure and honor of announcing and conferring our last award, which is our Young Leader Award. And this award goes to Mercy Esiedu. Mercy is quite a remarkable woman, as you can see in back of me. She is currently a PhD candidate in biomedical engineering at Duke. She's working with Dr. Nimi Ramanujan and their Center for Global Women's Health Technologies. She's also getting her certificate in global health, and she's a global health doctoral scholar. Mercy grew up in Ghana, completing Holy Child Secondary School in Cape Coast, and then she received a full scholarship to the University of Rochester. There she pursued a degree in biomedical engineering and in business, so a double degree. And then after doing that, she was accepted into the PhD program in biomedical engineering at Duke. At Duke, her research focuses on the development of low-cost imaging tools for speculum-free cervical cancer screening, and also the development of machine learning algorithms for automated risk assessment. She's trying to use her technological skills to address health disparities, such as cervical cancer in resource-limited settings, which happens to be an area that's particularly close to my heart. Her work has potential to enable women to perform self-cervix imaging and also to address limitations due to lack of trained physicians capable of providing cervical cancer screening, enabling widespread community-based cervical cancer screening. And obviously all of this is particularly timely in the context of WHO's call for efforts to eliminate cervical cancer. Outside of her work, her academic work at Duke, she is also extremely active. She founded the Duke African Graduate and Professional Students Association and was president of the group for 2 years, during which she brought people together by organizing conferences, mentorship activities, and networking events. So I think it's pretty clear that we have not only a rising star on our hands, but somebody who is really going to make major contributions to global health during the trajectory of her career. So Mercy, if you would join me up here, please. I am delighted to give you this award. Okay, so here we go.
Go for the picture.
There we go. All right, we get a picture first,
Yeah.
and then she gets to make a couple of comments?
Yes.
Okay,
Absolutely.
all right, we'll do that.
Okay. Here we go. And 1, 2, 3. Can we get one more? And just one more. Okay. Thank you.
Would you like to make a couple of comments? Please, go ahead.
Hi, I wanted to say thank you so much for giving me this award. Receiving this award takes me back to a moment when I was in high school in Ghana. A friend of mine, Rose, and I had broken some bounds to make some phone calls to our families at a teacher's house. We were in a boarding school, so you are not really allowed to have a phone or make phone calls. So we went to make some phone calls to our families, and over the call, she found out her aunt had died in childbirth, And just a few months before that, I had also lost an aunt to childbirth. And walking back to our dorms, we angrily discussed the injustice of deaths in Ghana due to childbirth. And at that time, our main experience in high-income countries was through movies that we watched that were based primarily in the UK and the US. And there it seemed like going to have a child was, something to be celebrated with balloons and teddy bears, and not like a life or death experience, like a 50-50 chance of dying. And for this reason, I really wanted to make women's health better. And at that time, I wanted to become the best obstetrician and gynecologist I could. Being at that time, the Ghana education system, it seemed like being a doctor was the best way to impact healthcare. So getting my scholarship to University of Rochester really allowed me to explore different courses and research and completely changed my trajectory. And I went into biomedical engineering because I realized that technology was really a rate-limiting factor for healthcare in places like Ghana, where I was from. And finding my doctorate thesis in developing technologies for cervical cancer screening to address health inequalities really gave me the chance to combine my technical studies with translational global health. And I've been working on the Pocket Colposcope, which is a low-cost tool for cervical cancer screening. It's portable and uses mHealth technologies for telemedicine. And I've also been working on the Colorscope, which really allows a woman to self-screen, do self-imaging of the cervix, which is kind of the follow-up to HPV testing. And so in receiving this, I really want to first thank CUGH for being a community where I really found a home in the United States, because here I've really found a group of people who are interested in the same things as I am, and thus addressing health inequalities. And I really consider these people in this conference my work family. And I want to thank Dr. Judy Wasserheit for this award in encouraging young people in global health to keep on pursuing this field. I also want to thank my family and my PhD advisor and mentor, Dr. Nimi Ramanujam, who has been so amazing to me and believing in me and pushing me to and past what I thought were my limits. And to the amazing collaborators we work with in Peru and in Ghana, one of which is right here, Dr. Emmanuel Sofrenia, who I'll be working with at Rage Hospital. And this is the last year I'm attending CUGH as a student. I hope to defend in the summer, but I will definitely continue to attend and increase my involvement as I go into my career. Thank you so much.
So with that, we're going to move into our next plenary. I'd like to invite the panel to come on up. Thank you all.
Good afternoon. Welcome to the afternoon plenary session. My name is Yannis Dupasis. I'm one of the associate directors of the Global Health Institute at the University of Wisconsin-Madison. It is my incredible pleasure to be here for CUGH's first ever session on emergency and trauma care. It is a pleasure to be here to discuss this somewhat forgotten public health priority, and that being emergency and trauma care development. A decade ago, the 60th World Health Assembly called upon member states to develop emergency and trauma care systems. Since that time, many groups have heeded the call and sought to improve these systems worldwide. However, emergency and trauma care remain a major public health issue, with death and disability related to injury reaching epidemic proportions. Over 90% of deaths associated with injuries occur in low and middle income countries. The care of the injured patient requires a multidisciplinary approach where a well-coordinated system exists, from time-sensitive care at the scene in ambulances, in emergency units, and in operating rooms, and finally through rehabilitative services that ensure return to function and true independence. Our distinguished panel today will discuss epidemiology, existing policies, share experiences in low and high resource environments, and outline examples of existing collaboration and best practices. We acknowledge that in injury there are two systems and two platforms of time-sensitive care for the injured. Obviously, we have had sessions on preventative injuries and preventative mechanisms, and we articulate that we were going to be focusing on the care of disease, knowing that injuries happen every day, everywhere, and every place. A brief introduction of our panel. First, we will have Dr. Terry Reynolds, who's the Emergency Trauma and Acute Care Lead in the Department for Management of NCD's Disability, Violence, and Injury Prevention at the World Health Organization. Second, we have Dr. Lee Wallace, who's the Head of Emergency Medicine for the Western Cape Government, Professor and Head of the Division of Emergency Medicine at the University of Cape Town, and the recent past Chair at the University of Stellenbosch. He also served as the past President for the African Federation for Emergency Medicine and the International Federation for Emergency Medicine. Next, we have Dr. Girma Tefera, who is a Professor of Surgery in the Department of Surgery at the University of Wisconsin-Madison. He also leads Operation Giving Back at the American College of Surgeons, where he coordinates programs in global surgery. Next, Dr. Robert Winchell, who is the Director of Trauma Center and the Chief of Division of Trauma, Burns, Critical and Acute Care at Weill Cornell Medical Center, who's a renowned expert in care for critically injured in the development and design of operations and trauma systems. And finally, Dr. Peter Donkor, who's an experienced medical educator and administrator. He's a professor of oral and maxillofacial surgery at Kwame Nkrumah University of Science and Technology in Kumasi, Ghana, where he has honestly held, I think, every single position at the university, from being vice chancellor to the president of the university to provost of the College of Health Sciences. Dr. Donkor has collaborated extensively with local and international partners and will be speaking as such. So I happily invite our first speaker to the podium, Dr. Terry Reynolds.
Thank you very much. It is an enormous pleasure to be here with you today. And before we start, I would just like to take a minute and ask you all to appreciate the fact that I am not wearing a navy suit. So I'm here to tell you a little bit about, from a few different perspectives, how WHO is currently working on trauma care. But I'm going to start with a little bit of the epidemiology. In some cases, I know I'll be preaching to the choir, but the numbers are so big and impressive that I think it's worth spending a minute on them. Every 6 seconds, another person dies, based on the updated 2016 statistics. About a third of these are road traffic crash, and absolutely mind-blowing, 16% of these are from suicide, 14% from falls, 10% from homicide, 7% from drowning. It would be as if this crash, which some of you may know about, many of you are too young, but widely still considered to be the worst event in aviation history, killed 600 people. 2 747s crashed in the Canary Islands. It would be as if this crash happened every single day. It would be as if half of the population of Bangkok or New York, all of the population of Chennai or Santiago, twice the population of Chicago, were to die every single year. So these are big numbers. They're so big that it's almost impossible to think about 5 million people and still keep in your head the idea of the individuals that die. So what we tend to do is we tend to talk about smaller groups, often of smaller people, the ones that we consider to be too young to die. So these are the new numbers that have come from the 2016 Global Burden of Disease data. And for those of you who think in terms of more high-profile agendas, the agendas that have been filling most of the sessions at CUGH, I hope some of these numbers will not change your mind about what's important, but help you integrate the idea that injury is a key consideration. So road traffic crashes are now the #1 killer of everyone age 5 to 29. Suicide is the #2 killer of youth 15 to 29. Homicide, the third top killer of that same age group. Drowning, the fourth leading killer of kids 5 to 14. So another way we look at this is we draw this, many of you will have seen this graphic. We represent injury with one stick figure, trying to make it comprehensible in order to say that it's taller than this other man who represents the entire burden of HIV, TB, and malaria combined. So injury in the new stats is approaching twice the burden of HIV, TB, and malaria combined. Now that doesn't mean that we should stop working on HIV, TB, and malaria. Why do we say this? HIV, TB, and malaria are big. So we're trying to make a relative point. We're trying to say injury is big, but we know it's big. There are a lot of big things. There are a lot of ways to say that injury is a big problem. Usually when we say this, the implicit point that we don't often make explicit is that our response is proportionately too small. So this is based on an internal analysis we did with a group at WHO, and it is 2017 Development Assistance for Health. The amount that went to those 3 conditions combined and the amount that went to trauma care. But you might say, but wait a minute, absolute numbers are always a little bit misleading. How can we talk about apples and apples instead of apples and oranges? If we make this a relative statistic, the amount of development aid relative to the burden, so this is in dollars per DALY for these conditions. This is HIV, malaria, TB, maternal child health, and this is not to say there's nothing wrong. $45 per DALY, nothing wrong with that, but this is what's spent on trauma care. We have made progress. We're not funding enough, but we have achieved an enormous amount in terms of how connected we are to address this epidemic in the last 2 decades. There are 4 distinct sustainable development goals and many, many targets, I'll talk about those in a minute, that address and incorporate injury. We have global reports on violence, on drowning, on rehabilitation, on road safety. The road safety agenda has made extraordinary progress. We've had the Decade of Action for Road Safety. We've had UN resolutions, WHA resolutions. We've also, though, had recently establishment of a trust fund. Much progress has been made in the area of road safety. We also have, for the first time, global open access platforms for collecting data on burns, the WHO Burns Registry, and also a WHO registry now for injury care altogether, so a trauma registry that low resource settings facilities can use to do quality improvement, but also to help better document the burden. And we have a range of networks, 300 organizations now that have come together to end violence against children, alliances for rehabilitation, violence prevention, and among these, the WHO Alliance for Global Care of the Injured, who several of the organizations represented today and the individuals here today have been part of, and many of you in the audience have contributed to. So we've made some progress. In many countries, things are looking better. But this has been extremely uneven progress. This is not the same trajectory in all countries. When you look closely, what you see is 2 different things. We've been less successful at prevention and care. And make no mistake, prevention is better than care, and we'll talk about that in a minute, but care has an enormous contribution to make. So what this shows is these are absolute rates per 100,000 population. So your chances of dying from an injury are much higher in a low-income country than a high-income country, nearly 3 times. But once you are severely injured, you are also almost twice as likely to die from your similar injury in a low-income country than a high-income country. So this is not an imaginary thing that we can achieve in a perfect world. This is what we know how to do in a high-income country. And you are twice as likely to die from lack of access to those services in a low-income country. So prevention is better than care, but there's not another disease for which we would write off a generation. We don't do it for HIV. We don't do it for rheumatic heart disease. We treat the generation that has currently been affected at the same time as we try to control, to eliminate, to eradicate the disease that's causing it. So now I want to talk about some small numbers and things that are entirely within our reach. When you look at the magnitude of this problem, it makes any action seem small. But we are enormously more connected to each other than we were 20 years ago. We know a lot more about what works. We have an entirely different potential to take action than we ever have before. And I want to talk to you about just one person who has. This is a nurse, Violet, from a hospital in Uganda. It was a district hospital at the time we did this work that has now become a regional hospital. And Violet was part of a program where we implemented, you're going to hear some more about these tools later, but where we implemented a simple 5-day basic emergency care course, the WHO Basic Emergency Care Course. Big part of it is a module on injury, just a simple approach for a frontline provider to anyone who's been injured. How you react, how you understand what's happening, how you understand what you need to do next, and when you need to send the person somewhere else. We combined that with some very simple process guidance that did not require the input of new material resources. So these were all basically protocols, techniques for focusing attention where it is needed. A lot of other things are needed. A lot of equipment is needed. A lot of more people are needed to work on this. But this was not that. This was a very simple intervention of raising the capacity to respond in a structured way to an acutely injured person. Some guidance about how to designate a resuscitation area and put what you do have right there. A trauma care checklist that doesn't even have to be printed. It's that one page that you see right there. You put it on the wall, and for each patient, whoever's at the bedside just runs through that and says, did I do this? Did I do that? You're done with it in a few seconds. And then a simple triage tool that doesn't even have to be used like a triage tool might be in a higher resource setting. It's just the idea of putting people into different categories, saying, you know what, we can do a certain number of things, and if we do them in this order, we will probably give more people what they need. And just to give you a sense of this is something that can be done anywhere. So a lot of the things that are sitting in that emergency trolley, none of them were new, but many of them came out of the closet. And what that means is you still have people dying in this hospital for the lack of things that exist in Switzerland or in Chicago, but you don't have people dying anymore for lack of things that are sitting in the closet. Simple colored cardboard, understanding which patients have a higher acuity, which isn't just a result of the severity. Acuity is the severity of the patient and the capacity of the system to respond. So it's about matching what you have to what people need. And a simple map of who's where. Simple cardboard identifying a bed, and those of you who are clinical providers in the room, you know this. You can't walk past your resuscitation beds without slightly turning your head. You just can't do it. It creates an addition of attention amongst the whole group. Simply the shared understanding. A piece of colored cardboard and some emails or a couple of announcements are enough to do it. So all of these are in reach. We did a year of baseline data and a year of data afterwards. And what happened across a lot of areas, but among other things, across 24-hour, 48-hour, and inpatient mortality, we had almost a 50% reduction in deaths from road traffic crash. Simple redirection of attention to where it is needed quickly. And this is something that can be done anywhere. These are the kind of contributions that will bring us closer to this goal. Now, many of you know, some of you have never heard of the Sustainable Development Goals and don't use them in your day job, and that makes a lot of sense. Some of you act at the policy level, and these have come to dominate all of your life and all of the hundreds of thousands of pieces of paper that you deal with every day. But the oddity of them is that the road traffic crash goal is 2020, and that has to do with the history of policy initiatives at the UN, and the others are 2030. So there's a really good chance that we will not achieve this. But what I want to talk to you about is what that goal implies, given the number of road traffic deaths every year, which is about 1.2 million, is that we need to somehow save this many lives from road traffic crashes every year. Now, I've said prevention is better, and that is absolutely true. It is better never to have been injured. Injury has all kinds of consequences: physical consequences, psychological consequences, financial consequences. It is better to have never been injured, and nothing will change that. However, if we were to scale up the fatality rates from severe injury in low-income countries and middle-income countries to the level that we've already achieved in high-income countries, this is the number of lives we could save every year. So I put this up here just to say that we should never, ever underestimate the potential contribution of care for this specific problem. It takes a long time to change roads and to change laws. The interventions that we know save lives and that dramatically change the care landscape are much, much quicker and simpler. It doesn't mean we should stop working on the others. It means we should be working on all of these things at the same time. And it certainly means if we want to achieve anything by 2020, these are things that the people in this room can do by 2020. It's going to be a lot trickier to change laws and roads and all of the other things that we need to. We do have a lot of progress in that area, new voluntary targets and indicators from the UN, and the agenda will keep going at the high level beyond the 2020 deadline. But in the meantime, today we want to focus on all the things we can accomplish with care. I want to make one other point about how we approach this when we think about the Sustainable Development Goals. You're in this room because you wanted to hear something about trauma, about injury care. But we may be preaching to the converted in this room. When you walk into a minister to talk to him or her about injury, you come in, you're the 8:45 appointment, and the 7 a.m., the 7:15, the 7:30, the 8 o'clock, the 10 o'clock, the 11 o'clock, the 1, 2, 4, 5, and 6 o'clock appointments, they all have their own agenda too. So instead of walking into the minister's office and saying, hey, I have another problem for you. I know you just talked to people bigger than me. I know you just talked to the World Bank about maternal child health. And I know you just talked to X, Y, and Z about A, B, and C. But I want to give you another problem. Instead, you can walk in and say, listen, my thing happens to be working on injury. I know a lot about injury. And we have a good solution for injury. But I want to bring you a solution. Implementing the solution that we know works for injury, organized emergency care systems, will get you all of these things for free. So depending on the audience that you are talking to, this may be an injury problem. The disease of it that you are interested in may be injury, but the solution in many ways is not injury specific. One thing I want to mention, especially since we have representatives from the Ministry of Health of Ethiopia in the room. I'm not sure where she's gone, but I know she's here. There she is. We take our mandate, this idea of integrated solutions that address multiple problems. This is the way that we have made achievements around this area of injury in the past. In the policy world, the World Health Assembly resolutions we have that support this work, the first one was called Emergency Care Systems, largely structured around trauma care, but formulated in a different way. The second was about resilience, disaster management. This mandates a lot of, or calls for a lot of the solutions that work for trauma care. Emergency and essential surgical care, a platform that serves a lot of other diseases, a critical platform for injury, but serves a lot of other diseases. And coming up now, thanks to the leadership of Ethiopia and the proposal from Eswatini, previously Swaziland, at the executive board meeting just in January, emergency care is on the agenda for this year's World Health Assembly. So going forward from right now, we have a new mandate that we'll formulate specifically in May. We have proof that the leadership of one person can totally change the course of an epidemic. We know what to do. And every 6 seconds, we get another chance to save a life on the way from 5 million down to 0. Thank you.
Hard to follow that. So, as Yanni said at the start, I work in a different sphere. I'm not with WHO. I do a lot of volunteering with WHO, working with Terry and her unit. But I'm in government in South Africa. I'm also in academia. Until recently, I ran 2 divisions. I now run 1. And I'm also in the professional society sphere, so having run South Africa's Emergency Medicine Society, and then the African one, and then the international one. But I'm going to talk about some of the work that comes out of Terry's unit and how governments and academic centres and professional societies can help to put that into real change at the front line on the ground. Taking the policy and product development that happens in Geneva and in the regional offices and actually making it into something that makes a difference to frontline providers treating victims of injury and other emergencies every day. Oh, excuse me. So, one of the things that came out very early, emergency care has only really been in WHO for 5 years. One of their first products was this, which is the Emergency Care System Framework. This is the infographic conceptualizing it, but there's a lot that goes behind this, using the WHO's building blocks for health systems to inform these different parts. But you'll see that emergency care is actually very simple. It's care at the scene, it's care during transport, and it's care at the healthcare facility. So at the scene, you need some sort of bystander who will do something when someone falls over in the street, whether they're hit by a car or they fall from a tree or whatever the incident is. Someone will somehow come and provide some care, a bystander, and they will activate the system at the same time. So there has to be some way of phoning for somebody professional to come and help you. When that response comes, you can either provide the transport care through a formal ambulance service where you have trained professionals who are employed in a service, or you can have an informal system using existing, say, taxi systems or buses that many countries have done successfully. But either way, in order to be care, it needs to not just be a driver. It needs to be a driver and a care provider. So in the back of that vehicle, there has to be a provider, and it's supported by a number of items of equipment and policies and protocols and so on. And then when you arrive at the facility, frontline clinical providers know this very well, but often don't know the rest of the system. But there's a handover process, there's a triage process, there's a registration process, there's some sort of screening for outbreaks. And then there's the clinical care that happens in the emergency unit, and there's the clinical care that happens in the deeper part of the hospital, in the operating theatre, in the intensive care as well. So this system framework and the supporting, this is just the infographic making it as simple as possible, but the supporting material behind it lent itself to something called a emergency and trauma care systems assessment. So this is a WHO tool that allows ministries of health in country to assess where their system currently is at today and identify gaps in the care that they're providing, right from the legislative framework that within which the care is provided, through scene-based care, through transport and pre-hospital care, through to facilities and onwards into critical care and rehab. And these assessments have been done now in about 40 countries, I think, in the mid-30s. And they allow for 2 things. First of all, they allow WHO to take its mandate from the gaps that are identified, and that's what I'm going to talk about first. And secondly, they allow ministries of health to develop a plan, a strategic plan to address the emergency care challenges that they have in their country. So I just want to show you an example. This is an infographic that we've used for a while. So at the time that this was done, it was a relationship between WHO, the Ministry of Health in Uganda, and the African Federation for Emergency Medicine, showing the old logo there. And the emergency and trauma care assessment was done, and the results were compiled, and there's a online or paper-based survey that you try and get upwards of 50 stakeholders to complete, and then a 2-day meeting whereby the results are turned into some sort of consensus. So you look at the spread of results that came in on each particular question, you try and agree what the actual answer is for those, and they produce some form of strategic direction for the ministry. But if you look at the 35 or so that have been done, you can identify some patterns in them. So if you look at the scene care part, you can see some across countries, you see this again and again. So most countries have no form of bystander protection laws in place. Many of the countries don't in terms of how to access the system, the population don't know what number to call, and there is no access to the number for them. And the dispatch of trained providers is not centralized in most places. There are many other challenges as well, some that occur more frequently than others, but these are the common ones that come up. In terms of the transport part, there's repeated gaps in the terms of the documentation that's done and the protocols and policies that support the care that's delivered. There's gaps in training and certification, so people produce some form of basic ambulance provider, but there's no central licensing or certification requirements for them. And many countries, most countries for low-income settings, the number of ambulances really is grossly inadequate to meet the need. When you arrive at the facility, there's recurrent problems around handover, around management of key emergency conditions, and around triage. Terry's already mentioned a little bit about triage, we'll come back to again. And then as you get deeper into the emergency unit and then into the hospital, there's the issue around the amount of care that's delivered in the emergency unit. Often these places are really just a front door for the hospital, and then there's a very quick decision of you go to surgery, you go to medicine, you go to orthopedics, you go to pediatrics, and they go elsewhere. So there's very little care delivered at the front door. And using that same model, the surgical team who's on for the day will rotate their junior staff down, and they'll see the surgical patients, and the medical team that's on for the day will send their staff down. There's no core of staff in the emergency unit. And when you get a little bit deeper into the hospital, there's clearly gaps in the resuscitation equipment and the resuscitation training in the emergency unit, but that persists right through into the operating environment and the critical care environment as well. And the availability of trained surgical staff, surgical personnel, and anesthesia and critical care providers is a recurrent problem across. So I'm not showing you one country's results here. This is of 35 countries. These are the recurrent things that come up again and again. So Dr. Reynolds uses this feedback from countries and amalgamates it and uses it to drive the WHO strategic agenda around emergency and trauma care. And these are the priority things that have come up using the data that I've just shown you. So developing pre-hospital systems, standards for quality improvement and data, emergency and trauma care training, the triage and other protocols, clinical protocols and policies to improve access to care have led to this particular bundle of products. So you've seen a little bit on one of Terry's slides. We saw that there's a little chart for the triage tool. There's a basic emergency care course. So they fit into these 5 groups. So there's a toolkit of standards and protocols for pre-hospital systems. So if you're setting up some form of pre-hospital system from your ministry in country or in a province within the country, WHO products now can help you not have to reinvent the wheel around how do you do fleet management? How do you run a communication center? How do people access your service? How do you provide trained providers who are skilled and have the equipment and the clinical protocols to provide care? There's a standard trauma chart which there's been a problem that we see in many countries that if you go into the emergency unit, if they do provide notes, it's generally just blank pieces of paper and people write road traffic accident, sutured, discharge, if they write anything at all. In fact, in many emergency units I go to, if you are not a red patient, a resus patient, you get no notes of any sort at all. So trying to help providers to both to capture notes more effectively, to drive quality improvement processes, but also if you structure those notes in an ABC manner, it actually changes the way the providers think about their approach to the patient. Because if the first thing they're writing is airway information, and then they're writing breathing information, then they're writing circulation information, that's how they start to think about their approach to the trauma patient. That's what we want them to do, ATLS type of thinking. And there's a data set, and you're going to hear a little bit about the registry as well, the trauma registry. Not all of the products have ended up as solely WHO. There's collaboration with the International Federation for Emergency Medicine and the ICRC around the basic emergency care course, which is a emergency and trauma care training for frontline providers who are qualified healthcare professionals. It's not lay people, but have had no formal training in emergency care. It's a 5-day course, and looking at different ways of delivering that over a shorter time period as well. The triage tool, a pediatric version and an adult version, a pre-hospital version, and a surge or disaster version, and checklists to go with that. So you saw the trauma care checklist earlier. Very simple tick box checklist that every resuscitation of a trauma patient gets that checklist done. Did you check for this? Did you make sure that this was present? Did you secure this? Yes or no? It takes a few seconds. And then the legislative toolkit. So that's how the emergency systems assessments help WHO to determine what their work should be. In terms of ministries, every country that's done this has turned it into a report from the ministry that lists a series of action priorities. So when we did it in South Africa, we ended up with 40 action priorities, and we ranked the top 9 of those, and they became the South African Health Ministry's mandate for the next 5 years. So their emergency care directorate in the ministry were told, here's the 9 things that you will do for the next 5 years. That is your work plan. That's happened as well in Ethiopia. It became integral to the Ministry of Health's emergency care agenda. Other countries, like Sudan, for instance, have decided to work with WHO directly to try and workshop taking their 14 top action priorities and working out how you actually do them step by step. So what's the first step that we do for this action priority? How important is it? What budget will it take? Who's going to be responsible? Where's the workforce to do this, and so on. But either way, taking the results of that exit to give the ministry its mandate for the next 3 years, 5 years, for its strategic improvements in its emergency care system. So ministries will, of course, turn around and say, okay, we're going to do all of this, but what difference will it make? So if you actually look for evidence, it's a real problem. There's a big gap. I just want to show you one systematic review that came out of WHO that addressed this very question for trauma. What's the impact of trauma care on patients or on the system? And from thousands of articles that were found, there are actually only 71 that really addressed the question. The overwhelming majority of them came from the last 10 years and from very few low and middle income countries. A very small cluster. Most countries are actually unrepresented in any form of evidence around trauma care's impact. And it's not the best projection, but you see at the bottom that a decent amount are about pre-hospital systems, but the overwhelming majority are about training. And with training, a lot of those are about, do people retain the knowledge that they get? Does their pre-post test change when they do the training? Which is useful to a degree, but it's not telling you about what's happening either to the system or to the patients who come through the system. So just a different representation of that. And most make some sort of attempt at some clinical outcome measure, but there's a lot of structure and process oriented papers out there as well. But it's really only 71. It's from a small number of countries. And this is the problem. Not only do we know that in country after country where you do the assessment, you will find the same. There's a gap in legislation, there's a gap in protocols, there's a gap in training. But also when you look at the evidence that's out there, you'll see that most low middle income countries are completely unrepresented in terms of any meaningful emergency or trauma care impact assessments. There's a bit of basic demographic stuff out there. There's a bit of basic epidemiology. But most of that as well is in central academic sites. We have almost nothing from district level or rural emergency care. And when you look at the evidence that is out there, so in this systematic review, there's almost nothing on rehabilitation, which, again, to echo that prevention is the most important part. Then there's the care part in the acute phase, and then there's the ongoing surgical and critical care. But if you don't provide rehabilitation services to patients, you don't get them back to being productive members of the society in the most meaningful way. There's legislation and government gaps, and there's almost nothing out there on pediatric trauma care. So there's a lot of gaps. There's a lot of products coming from WHO. There's a lot of gaps in the literature. There's a lot of gaps in emergency care systems. So the question is, as an academic, as a government official, as a professional society lead, what do we do with all of this? So I think the key message I want to give to this audience, which is different to our normal emergency medicine audience in conferences, which is mostly frontline clinical providers. This audience, thinking about systems level, thinking about health policy level, thinking about research, academic products, I think the steps that I would recommend that we really need to focus on are that many more countries do the EXA, do the systems assessment, and if this resolution comes through in May and if it gets voted on and passed, then we'll probably see quite an increase in that. But it's not just about knowing that you have some gaps in your country and you have a strategic plan to deal with it. You have to actually be able to move forward on that. And most ministries that don't have effective emergency and trauma care systems at the moment are not really in a position to effect massive amounts of change by themselves without the assistance of the academics in their country, the large hospitals in their countries, and the professional societies in their countries or in their regions. So it needs to be a collaborative effort, and I would encourage all of you to engage in that effort. And for those of you in academic positions, we've got to do better with the evidence. We have to do better with both the knowing who's coming through our trauma system. We know the gross numbers, but who are we seeing? Because for the 5 million deaths Terry talks about, for every death, there's something like 20 to 50 hospitalizations. And for every hospitalization, there's an order of magnitude more people who present to primary care with injury, and there's an order of magnitude more for each of those of people who just do self-care for injury. So we really don't know the epidemiology of it in a robust way, and we don't know the impact of what we do. So partnerships between ministries, between professional societies, WHO, and then academic centers through organizations such as CUGH, I think is the way that we really need to try and push for the next 5 to 10 years. That's all. Thank you.
Good afternoon. Yanis, thank you for the introduction earlier, and I know Dr. Martin just left, but I just want to say congratulations for a well-attended and a well-organized meeting, and congratulations also for having this kind of a discussion about an issue that is really critical for the global world. So we really face this epidemics everywhere, including our country here, but more importantly, in the 2/3 or almost 75% of the rest of the world. I mean, it's really an epidemic proportion. My role in this is really to talk to you about a couple of things that are going to add value to the discussion that has been started. And I'm just going to actually, in a few slides later on, present to you a model where we can maybe address some of the challenges we face. I am a surgeon. However, most of my work has really been in a collaborative environment with internal medicine, with emergency medicine, and other disciplines in addressing global health issues. Because if we don't do that kind of a collaborative approach, I really don't think we can build resilient systems. And unfortunately, that has not been yet the norm. I was actually in Ethiopia, in the southern part of Ethiopia in a city called Hawassa. This past week, I just actually got here this morning at 6:30 a.m. on a direct flight. And on Monday morning presentation, here is a list. I don't know if you can read the list of patients that were acutely admitted and required surgery. So it's just an incredible list. And I just marked with in yellow all that required surgery and were secondary to trauma. And there were probably a few more that I was not able to write down. So the bottom line was it just it made me think two things. One, the very visible, overwhelming situation of trauma care. And the second, as a Western-trained surgeon, I really felt inadequate to see the amount of incredible work they were doing in this university hospital. I say inadequate because we are so super highly specialized. Some of the general surgery chief residents were doing burr holes and elevating fractures that are depressed in the skull. And so the reality is there is so much we can learn by being there, as much as we can teach. And the lessons where I am inadequate, there is a lot for me to learn from here. So surgeons have been really new, relatively speaking, to the global health arena. I'm not sure if it was because we were not welcomed or because we thought we were not, public health officers. But I think the call to action was many years ago, as you can see from this slide. But it looks like we really woke up in the last few years and found the global health community. And we are really working hard to be part of the ongoing contributions to the global health activities. Clearly, we are looking to the two very important leaders at the World Health Organization that have kept us informed and have been leading the way with the two at the helm, both Terry Reynolds as well as Walt Johnson. I think the care of the injured patient is going to be significantly improved, and as you have already seen from the presentation, there is a huge amount of work that is being done, and we just need to really reach out, do what we can, and contribute to the effort that is ongoing, because we are in that continuum and we are on that same action plan, if you will, and without all of us working together, clearly we cannot achieve our goals. And Terry, I really appreciate your leadership in this, because when I went to Hawassa, one of the first things I saw was they were trying to implement the list in the emergency department. And so there is already action that is happening on the ground. The two things I see when I looked at surgeons within our organization at the American College of Surgeons is that we are a little bit everywhere. We are so spread, and we don't talk to each other. And this was very clear, because sometimes people may be 2 miles apart and have not even met, and they don't really have even discussions about what they do when they are back in their home institutions. Sometimes it's from the same home institution that they have gone to similar places and not talk to each other. So yes, we are really trying to participate, but we are totally disorganized. And so this disorganization has created so many silos. And these silos are leading basically to waste of effort, waste of resources, and it's very clear that the cause of these silos is basically the slide Dr. Reynolds showed earlier. There are limited resources that we're fighting for. And so we're trying to stay in our own little space, whereas actually, if we come together, we can maybe avoid duplication of efforts, and our resources could actually go a long way. So for this purpose, one of the things that we thought about is we need to kind of create a tent, kind of try to unify our efforts so that we can join hands and move towards doing a much greater job. This is a report from the WHO, and as you can see from this slide, it says that actually human resource issue is the #1 issue. So academic institutions should really be investing a lot more in this, and CUGH is a perfect place where all these academic institutions are coming, and it seems like the right environment to discuss this challenging situation in low-income countries, if you will. So the idea or the model we thought of is pretty much simple. So how can we create some kind of a model where we can go beyond the good and feel good to develop an environment where we can have a global learning atmosphere, where it's not only surgeons or emergency medicine or internal medicine, but actually all of us, because there is really no system without all of us across the medical disciplines participating in that realm. So with that, we just wanted to pilot for the next year or two by identifying a geographic site, bringing some US institutions together, and trying to create that environment for learning and see if we can model this and subsequently expand. And so we went through a long exercise to select a site, and we have, at least from one site perspective, this site in Hawassa, Ethiopia, that was chosen last year. And what we basically are trying to do is trying to model where academic institutions from the US, you can see on that slide here, where there is 14 of them have agreed to participate. So what this is going to create is going to create a continuum of care. It's going to create a reliable, sustainable teaching environment. It's going to create an environment where research can be easy. It's going to create a situation where patient care is going to be actually not done in such a way without any continuity of care. And so with that in mind, we have started actually having people on the ground continuously throughout the year, having a rotating schedule. And the US Department of Surgery are not sending only faculty, but they are also sending learners, so that those learners will have an opportunity to actually be innovative and creative and come up with some new solutions. So we are hopeful with this kind of a model, if we test it, if it goes through by developing this kind of programs that bring the academic institutions from the US together, we can really be successful in building resilient systems wherever we are working at, with impact that beyond the institution or the specific geographic area, it might actually reach a wider audience where we can easily transfer skill, knowledge, and whatnot, and actually ourselves also learn. And clearly the faculty development for both sides, both for the US faculty going to the low-income countries, as well as the low-income country faculty coming towards the high-income country faculty. So the idea is testing one site. Who knows if that can be replicated in a timely manner in 2, 3, 4 different places where it can have a very deliberate and intentional regional impact, where we can really teach and expand the workforce as well as impact on the care of the patients. So this is just a brief report that I did by being on the site. And here on this picture, what you see is the chair of the Department of Surgery. You see the two ladies in the middle are from the US. They are trauma and critical care surgeons. working next to an emergency medicine physician who is also critical care boarded. So they were actually working on the critical care issues. And then next to them is a trauma surgeon who deals with a lot of the broken bones. So there is already on the ground actually a multidisciplinary approach to taking care of patients and sharing resources. So one of my last slides here is really the way forward, the way I see it, is by creating this, this model by joining hands, not only the academic institutions, but also organizations and societies, because there is a lot more that can be added so that it can bring some additional added value. So I'll leave you with this slide, and if there is any additional questions or if anybody wants to reach me, there is our website where I can be reached at. And I really appreciate the invitation to come and speak at this panel. And thank you very much. And if there is any questions, I'll be happy to answer later. Thank you.
Good afternoon. Again, I'd like to thank the organization for the opportunity to speak here. Again, my name is Robert Winchell. I'm a at least partially reformed trauma surgeon. And if I can get, the part that I was asked to speak about is looking at translating some tools, I think, from what might argue is mostly a high-income country setting to an implementation in other areas of the world. I have nothing in particular to disclose. This is an idea of the context, looking back at the WHO framework, and I'm mostly focusing on the definitive care facilities. We talk a lot about prevention, a lot about pre-hospital care, but in that red box really is what happens after you walk into a hospital. And I would argue that all of the other systems for transport don't make a whole lot of difference if you get brought instead to a McDonald's instead to a hospital, or to a hospital that doesn't really know what to do with you. And then even more than that, perhaps, in terms of hospital capabilities, the bottom part and everything to the other side of the document really is what happens in the first few hours that you get there. What happens to you in the definitive care facility is probably the next days, weeks, months, or in some cases years as to what goes on. And so, in fact, some focus in this area I think is critically important. So you've heard a little bit about it already. I can't help but go back somewhat. Injury really is a disease process. It's not a sporadic thing that happens to the other guy. It's not something that we just take care of when it comes along. It has its own epidemiology. We do a lot of work around prevention and its own set of specific therapeutic interventions that are tailored to trauma, and people clearly do better if there is a systematic approach to injury care. It saves lives in the major high injury countries or high income countries. It clearly works to do so in low and middle income countries. And really to implement systems of care, just like for infectious disease or other things, you need policy level intervention. It doesn't work strictly at the level of training providers working on individual ambulance units or individual hospitals. If you look at how these systems of injury care have grown up, the first ones that have come up in the States and other high-income areas of the world really grew up organically. They grew out of an arid world where there really was no systematic approach. There was no coordinated approach to the development, and there was high geographic variability. And if you wind up in the right part of the right city, you might do very, very well after catastrophic injury. And if you wound up in the wrong part of the state, you'll do very, very poorly. A colleague of mine likened it to having a dart thrown at the wall, and wherever the dart happens to hit on the map determines your outcome. And that geographic tendency is still very much true even in the States today, because it's a very much of a patchwork arrangement how well we do at trauma systems of care. New systems, on the other hand, especially new systems in low and middle income countries, are not developing in that same vacuum. They develop in context. We already know on a global scale what things work. We know what things really matter and where the focus ought to be. And we have a way to really guide the description or guide the way that things develop without waiting to see what happens randomly. The key really is adapting and implementing lessons that may have been learned in a very, very different part of the world, realizing that principles are in fact global, and those can be imported to almost any setting, but the solutions are local and they have to be specific. So at some level, to know where you're going, you have to know where you've been. The other one I like is that, in fact, to try and avoid the fact that the lesson of history is that the lesson of history really is not learned, I'm going to go a little back into the history of how these systems of care developed here in the States, specifically around standards for trauma center performance. So prior to the 1960s, I would say that the systems for trauma care in the United States were not much different than in many low and middle income countries where we're trying to work these days. There were systems here that were developed during wartime when people were very, very good at causing injury. You had to get substantially better at fixing injury. And there were very sophisticated systems set up around major global conflicts, which were then rapidly deconstructed when people weren't shooting at each other anymore. And the lessons learned between conflicts tended to be lost. In peacetime history, there was really nothing to maintain the system. And again, back to that lessons of history. Each of our armies tended to go into war with the medical technology of what they had before. So we entered World War II doing medicine a lot like we did in 1918, and so it goes. On the civilian side, trauma systems didn't exist at all. Injury is not a priority for public hospitals or private hospitals. They would take care of you if you showed up, but no one really made a science of it. Military lessons weren't transferred in any way whatsoever, and so it was really just this hodgepodge. And by the early to mid 60s, the Vietnam era leading to a lot of other social changes around here, the military had actually gotten very good, working from World War II to Korea to Vietnam, which happened in very short sequence. We got really good at the point of care injury, very good at systems of transportation, very technically advanced forward surgical facilities and facilities in the States to provide late care, with major improvements in outcome after casualties over the course of that. And a lot of surgeons coming back from Vietnam, knowing and having lived in this existence, only to find, as many of them commented, that you probably would be in better shape to get injured in the Mekong Delta than you might in the middle of the south side of Chicago or certainly in a cornfield in Nebraska. And that led to a report from the National Institute of Science or National Academy of Science in 1966. And if you go back to some of Terry's first slides, we called accidental death and disability the neglected disease of modern society in 1966. One of my favorite lecture tricks is I can use the executive summary from that paper and I can put it in my slides today and it pretty much still works. Because many of the things that were problematic in 1966 are still problematic. We don't invest in injury care. We don't invest in the research. All of those sort of NIH dollars looks a lot like all of the little bubbles of who and where the investments go. And so in many ways, we haven't gotten better at certain parts. On the other hand, we've gotten better at others. The report looked a lot at the advances in military care, and it looked a lot at advances that had been made in the care of infectious disease and proposed looking at injury as a public health problem deserving of a public health solution, and led to some of the first public or policy level interventions in the states around EMS and around the setting up what it takes to be a care facility. That was picked up by the American College of Surgeons, where I spend an inordinate amount of my time. We like to do standards and we like to do rules, and over the course of about 30 years, we've been refining what it takes to be a trauma center to come up with a very particular set of standards. There's some 200 of them in that orange book at the bottom, which are as specific and particular as the U.S. income tax code and equally transportable to another environment. On the other hand, the concepts behind those standards really, I would say, are far more generalizable. And focusing only on three, our document focuses a lot on the concept of the trauma team. that there needs to be somebody in charge, that somebody in charge needs to know something about injury care, rather than just be the person who was standing around the emergency department on a given day. That they need to have a surgically focused view of the care of the patient, only because injury tends to involve surgical intervention, whether for control of hemorrhage, for repairing fractures. There's any number of things where it's more skewed towards surgical intervention than many other medical or infectious disease related things. There's a focus on processes of care. I don't have to figure out what to do with a gunshot wound at 2 in the morning, because that can be a big problem. I can sit around at 2 in the afternoon when the lights are on and try and figure out how am I going to deal with specific problems? How am I going to mobilize for these events that I know will eventually come along? So I know how I'm going to set up my emergency department. What equipment do I need in my emergency department? How do I access the operating room? How do I access blood? How do I access people? Those are all preparations that can be made well in advance of when you need them, and you do better inventing things in the middle of the afternoon than you tend to in the heat of battle at 2 in the morning. And then finally, there's a huge emphasis on data collection, being able to tell what you've taken care of, what you've done, and how those people did, to be able to identify problems in the system and go back. So of the standards in the US approach, probably a third of them, between a third and a half of them, are focused on data collection processes and quality assurance processes to make sure that we're going back and looking at the things that were done and looking to fix the problems that arose. So how do you apply something like that in a local setting that lacks the resources or maybe is put together differently? I try again in 3 sort of short examples. What about a trauma team? So in the US, your trauma team will be led by a surgeon like myself. It'll have a certain set of things. I have to be certified by the American Board of Surgery. I have to have this much study. There's a whole list. Well, depending on where you go in the world, there may be nobody in my job description as a trauma surgeon, or that trauma surgeon may be an orthopedist. The person leading the charge may be an emergency physician. It may be an anesthetist. It may be a health aide. It doesn't really matter. What matters is they should be trained at the level that is appropriate for the resources. They need to be schooled in what it takes to take care of injury at the level of the resources that are available. So again, the specifics need to be tuned to the local site. You need to maximize your capability for surgical intervention, because those tend to be the early things that need to be done. And that's, again, knowing that the surgical providers, whether they're American Board of Surgery, whether they're properly trained by whatever board that certifies surgeons in whatever portion of the world you are, but they shouldn't be the guy that walked in off the street. And again, whether they're very low in the amount of training because of local resources, there still is a certification and a training process to make sure that your surgical resources are the best that they can be. And then you have to define criteria for how they're available, when do you get a hold of them, what are the expectations, all of which, again, can be tuned to the local resources available. And processes of care, we talked about, we saw a picture of the WHO checklist is a perfect example of processes of care, things that we know work that can be implemented to make sure that the trauma evaluation that gets done, regardless of who it is that might be doing the trauma evaluation, isn't going to see a broken femur, stop there, and go to the operating room only to have the patient die of the broken spleen that nobody looked for. That there's a pathway, that there is an appropriate set of steps that are done by whomsoever is in the early evaluation to ensure that we don't miss injuries, because we know this works. Why do I know this works? In 1984, that same problem might have happened to you in Orange County. We've just gotten a little bit better at it here. You need to maximize the capacity for surgical intervention. That means sorting out what operating theater capacity there is, what it takes to spin it up in the middle of the night, where the people are, where they'll come from, and how you oil that machine to make it work when you need it to work. Is there any transfusion support at all? If you have a blood bank, how much blood do you get? Can you take blood from wherever you can get it? But at least, again, planning ahead for those processes of care that can be scaled to what resources are available. And then you can plan for specific patterns of injury long before they show up. I don't have to get my first big epidural with a blown pupil to understand or to at least know what it is I'm going to try and do for that patient when they show up. You know, and it may be nothing in some parts of the world. It may be a craniotomy. It may be trying to get them the heck up the road to another hospital. But I can have a plan, and that saves time in implementation. The same is true with a gunshot wound or a pelvic fracture and major hemorrhage. For a mangled extremity, all of these things can be planned for, and you can have the processes in place. And that goes a long way to building the capacity of the facility, regardless of, in fact, whether that facility is a one-bed clinic or a 1,000-bed referral hospital. Because in many cases, these are not issues that people have ever really thought about, again, because injury is not always a priority. Finally, in terms of data and QI, as a trauma center in the US, you have to submit 250 or something data points to a national data bank, or you don't get to play. The fact is, what needs to happen is data collection even at its most basic. We have several models for minimum data sets, for ways to try and collect a very basal set of early epidemiologic and early outcome data. Again, you saw some of the work from the WHO around implementing a system and associated documentation. There are several other similar implementations. The trick is to understand the importance of getting started and getting the providers at whatever level to understand, getting the data together, and then going back and looking even at the most basic outcomes from that data, whether it's strictly numbers, whether it's early basic outcomes like mortality, and trying to use that data to guide improvements in the system. So in summary, having hospitals that are skilled in trauma care is absolutely essential to decreasing the burden of injury, whether you're working in the highest of high-income countries or the lowest of the low-income countries. That policy will enable things in those hospitals that volunteerism or the desire to do better simply won't. That setting standards and setting regulations around what you have to have will move the ball along. We know from extensive literature in the US and other places that establishing standards, even if the standards themselves have no particular evidentiary basis, establishing the standards and adhering to them improves outcomes across the board. And also we've learned that compliance with standards or working toward a set of standards improves capacity in the facilities that are doing that work. And I would argue very strongly that our experience from the high-income parts of the world is not specifically movable, but the concepts are translatable, and they provide a framework to keep us from having to reinvent every single wheel as we go along. And finally, above all, data collection is really important, and it's one that tends to get glossed over or not pursued because it's hard. But you don't have to start at the top of the pile with 1,000 data elements. You have to start somewhere to build the circumstances around collecting data and understanding its use locally. And that's where I'll wind up. Thank you very much.
Mine is the last talk. What is between you and your break? My talk is just really to highlight some of the research that has been undertaken in my part of the world as an illustration of the role of research in improving trauma systems in developing countries. Thank you. Thank you very much. So I'm going to talk about some of the research partnerships which have taken place between my university and a couple of universities in the US, University of Washington and University of Michigan, and the impact that these have had. So the University of Washington has had a long relationship with my university in Kumasi for more than 25 years, where we have largely been supported by NIH funding within the last 14 years and undertaking training in injury control research. We've targeted training of candidates at the level of MPH and PhDs, and also we're running some short courses training them in research on injury. And all the trainees undertake research projects to guide interventions in trauma care. So, as I said, the short courses, and some of them undergo attachments in the University of Washington, but they do the degrees in my university in Kumasi largely. So for the short courses, we've trained journalists, we've trained parliamentarians, especially those from the committees on health and transport. We've had several trainings at the West African College of Surgeons conferences, and where we train them on the trauma systems, and these are very well attended. I mean, the last one we had was in Burkina Faso in 2017. And in the course of that, we found that since the training of the journalists, they give good headlines. Now, our trainees undertake a variety of research projects, and they come from a whole range of backgrounds. Some are from surgery, some are from emergency medicine, some are from nursing, some are from education, and the research spans a whole range of topics, from vehicle speeds to child safety, etc., etc. And the research covers a whole spectrum of injury control activities, from surveillance, prevention, pre-hospital care, and hospital care. And one of our first scholars, he looked at some mortality data from our mortuary, and in the first time they looked at it, they were reporting about 70 cases a year, and then when he looked at it, he realized that they were missing a lot of data, and they reported about 600. Subsequently, the data has improved, and it is now they are capturing the true state of affairs. I think what the main message that came out of his work, which has been shared with the police and other research institutions that capture data on injury, is the need for us to have reliable data registry, especially for injury. You know, you've seen this picture, and if you look at that, you see this shows the speed at which one may get killed. And so at 50 kilometers per hour, probability of dying if you are struck by a moving vehicle is more than 0.5. And so one of our trainees decided to do a study looking at vehicle speeds on a major highway in Ghana. He stood in a town on the major highway and looked at 20,000 vehicles, and you don't have to be he saw that this is 50 kilometers per hour. Majority of the vehicles were way in excess of that. So in that town, anyone that was hit by a vehicle, be that a child, an adult, or a goat, had a risk of being killed. And so this got a lot of exposure in the newspapers. The results were published, and the government took it up. And I think there were some pictures that have disappeared from there. Oh, sorry about that. Yeah, no, keep it. So now speed calming devices have been introduced based on this young man's work. During the last election, we drove past a town and there was a sign that said, no speed humps, no vote. So the ordinary people are now demanding speed humps in the villages, and they are making their own makeshift speed humps when the government doesn't create one. Some of our trainees have looked at, preventable cause of death in trauma victims, and they have set up panel reviews which have made recommendations on how care could have been improved. This is actually a lot of these, a lot of the inputs to the research has resulted in the establishment of this is a new emergency center, which now is where our emergency medicine trainees are being trained. So that takes me to the next level of our collaboration, where University of Michigan partnership, again funded by PEPFAR, got into the training of emergency physicians with the help of technical support from University of Michigan. We started a training program with a locally developed curriculum, which was based on a partnership with the University, Michigan, teaching hospital, the Ghana College of Physicians and Surgeons, which is responsible for training postgraduate doctors, National Ambulance Service, and the Ministry of Health. And the curriculum was accepted. A similar curriculum was developed for nurses. That was also accepted. Now we train emergency physicians and emergency nurses in country. Thankfully, we've produced enough products now. This is the training program, and with some visiting faculty there. Now we have about 42 emergency physicians and about 400 plus emergency nurses. The program, even though the funding has stopped, is sustained by the Ministry of Health, and the Ministry of Health pays for the training. The current head of emergency medicine is a product from the initial cohort of trainees, and the products are spread all over the country, especially in the regional hospitals providing emergency medicine services throughout the country. And some of them are even helping develop similar services in other West African countries and Ethiopia. But inbuilt into the training program is research. So at every step of the way, they have to conduct research, local research. Now, this is the first group of emergency physicians trained in Ghana, and the gentleman in scraps, blue, he's the head of department, current head of department, young man. So they're everywhere. When there's disaster, they're called upon, and they are very useful to us. Now, to conclude, these research collaborations have actually led to the training of individuals whose capacity has been built, who have remained in Ghana, and are serving in very important roles. A new service of emergency medicine has been developed. Some of the research has led to real changes in policy by government. And because the research is ongoing, they contribute to the international literature so that our experiences are also shared elsewhere. What we are struggling with now is to have a data registry which will ensure that there's absolutely reliable data on injury, for which we look forward to collaborating with the WHO on this. So Terry, this is for your ears. Okay. So thank you very much.
Thank you so much. I want to extend a great thanks to our panelists and to CUGH. We look forward to this springboarding many more conversations like this in future sessions. The most important thing that I've learned about facilitating this session is making sure that each speaker goes over by a few minutes, so it leaves me with only 1 minute to do facilitated questions. That being said, the most important questions are going to come from the audience. So if there are questions, please step up to the microphone, identify yourself, and pose the question. I think the one facilitated question that I did want to bring up is in many of the presentations, the funding discordances. And so how is injury being addressed by funding agencies, and sort of what is the outlook? And I pose it to the panelists. How is it being addressed, Terry?
I would say the one-word answer is poorly. I really do think that I'm not saying this is how it should be. We should be able to get more attention to this issue by just asking people to look at the global burden of disease. This is not a challenge. This shouldn't be something that we are advocating for because it's our particular interest. Every single meeting that happens on UHC on addressing the global burden of disease, given where injury is, at what ages, injury should come not necessarily to the very top, but very close. And that just doesn't happen. So given that, I think that we really have to take a strategic approach in which we discuss the ways that the platforms that address injury, the critical platforms, which are emergency care, surgical care, critical care, and rehabilitative care, we need to talk about how those platforms, the benefits they provide for other diseases that have been more successful, honestly, over the last several years, the last couple of decades, really getting attention at the same time that we advocate for injury in a disease-specific way.
Yes, right.
Hi, Jim Kobe from the G4 Alliance. I noticed in many countries, Tanzania, Malawi, and Ethiopia, everyone's looking at ATLS and learning ATLS well. But still finances, when I was in Congo, in DRC, if you come to the hospital, a trauma hospital, a major surgical hospital, without money to pay for an x-ray, you might as well go home. Finances are the issue in many hospitals.
See whether that's actually on? I guess it is. So it's hard to argue that finances aren't a big deal. They're a big deal here. But I would still argue that even lacking the high-end pieces, the approach that one takes to injury, if you have the appropriate trained people, that you can do a lot more with the resources that you have, which is the unfortunate position that we're stuck with, at least, until we get better funding for trauma. And again, I would argue that you don't have to be in a low middle income country to have that problem. We're sitting right in the middle of one, where I can get every person in the NFL out to wear a pink uniform for breast cancer, but you don't find them doing the same thing for trauma.
I'd say that whichever country you're talking about, the list that you produce of low-income countries, it should not be followed by the 4 letters ATLS. It's the wrong course for those environments. It's too expensive. Most of the material in it is not context appropriate. What's needed, for starters, is a basic grounding for all frontline providers, like through the WHO's basic course, and then a context appropriate advanced course for a select number of providers that is affordable and is resource sensitive. And it's not just in the case in trauma, it's the same in advanced cardiac life support. The AHA courses have no place in Malawi. They just currently, 30 years from now, maybe they do, but something that is locally appropriate for the African context is what's needed and that's accessible at the price point that most providers can afford, which is a handful of dollars, not several $100s.
Well, I guess, Russell Anderson, World Federation of Neurosurgical Societies. We've had great, this session has been great on training programs, and I think we'd all agree that prevention is better than treatment for trauma. I've been thinking of the Pense Bem program in Brazil in the elementary schools to educate young people about avoiding trauma. And this could apply to other things such as smoking or poor dietary habits. But I think that they've gotten into the school systems, and a few years ago it was taught to more than 30% of all the young elementary school age kids in Brazil. I'm just not aware of any sessions in CUGH on educating the very young on trauma prevention. Maybe that's something that could be investigated.
Dr. Martin is committed to CUGH 2020. Thank you for leading up that panel next year. So.
And I would say the answer to that comment really is yes, of course. And this panel was focused specifically on trauma care, so does not in any way purport to cover those, especially in terms of WHO's investment or resources that are committed to it. There are maybe 20 times the human resources at WHO alone in my department focused on prevention than on care. And I think that balance is appropriate. So that's how it is. There are a lot of interventions, especially around drowning, that are among the new interventions getting a lot of attention for school-age children.
There's somebody that's been patiently waiting in the back right there.
Teresa Chin from University of California, Irvine. As a burn and trauma surgeon, I'd love to see burns next to everywhere you have trauma in all of your slides. It's often forgotten and neglected, as trauma has been to the world of global health.
So burns is one of our most extensive programs at WHO in terms of data and care. I would argue with putting it next to trauma as separate, because I think it's an integral part of trauma care. But I agree with you; it's often neglected in the list and what's in parentheses after injury.
Right here in front.
I'm Roshna. I'm from Nepal. I'm a general practitioner and an emergency physician. In LMIC country like ours, it is not feasible to close the gap with having a surgeon and a gynecologist and an anesthesia personnel in the rural area. So in our country, we have a model called rural general practitioner who is trained to do basic emergency laparotomy, cesarean section, and manage orthopedic emergencies like open fractures and all. So could this this was not mentioned in any of your presentations, so I thought could this model be a model for LMIC countries to fill in the gap of having such manpower in those rural areas?
I would just say that that's among the very important reasons why we try to formulate everything within the WHO framework as a function. So in no way are those functions expected to correspond to the same human resources that they correspond to in high-income countries. I think you're absolutely right. And if we pretend that we're going to be able to disseminate specialist-level providers in either of our areas, in any of our areas, it's imaginary. I think specialists have a certain role to play in terms of advocacy, in terms of teaching, and in terms of the capacity to bring an idea and an issue to the forefront with ministers. Ministers like to talk to specialists, but that's it. That's the most important part. The rest of it, care delivery, I think is not going to be successfully, we're not going to achieve what we need if we focus entirely on specialists for care delivery. Nurses, in fact, are delivering most of the emergency care in the world.
No, and I would say positively, yes. The key there is in including that, okay, I know I have an obstetrician, they're around, they know how to operate. I need to take the time to teach them what to do with major hemorrhage in the abdominal cavity. Or conversely, if I have a general surgeon who's good at taking out spleens, they need to include cesarean section in their armamentarium. And I think that's very much about leveraging what surgical resources you happen to have, even if that may be a high school graduate who's happened to pick up the training.
I think people have come around really well, too, to the idea that every emergency provider needs to know how to take an initial approach to injury. And I think there's still work to be done in communicating this idea that every surgical provider can really do an enormous amount with a simple short course that allows them to convert the surgical skills that they may have to effective treatment of injury, effective operative treatment of injury. You can't do everything, but they can certainly do a lot. And I think that's an area for advocacy we need to focus on a little more.
And we'll take the last two questions right here. If you guys could do them sequentially, and we'll have the panelists address the last two questions. So right there in back of the microphone.
Sure, thanks. Fiamma Mariaco, UT Southwestern, Dallas. And I just wanted to see if the panel would address the post-injury disability spectrum of injuries. I know we've talked about pre-hospital and in-hospital, but frequently the rehab and the patients that are taken out of the population and the workforce require significant resources over the ensuing months to years, which generally doesn't involve surgeons, but physical therapy and all the other interdisciplinary teams that have to work on them. And so how much does either the WHO, the ACS, or any of these groups place on getting those folks in as part of this team?
And we'll take this last question right here and then hopefully address both the questions of the panelists.
Enrique Steiger from Switzerland, former trauma surgeon transformed into a reconstructive surgeon, and heading a foundation which is and a frontline practitioner in armed conflicts. And our foundation is specifically interested in improving the access of victims of war and the quality of treatment in this environment. And what I heard today was actually quite interesting, especially from Dr. Tefera and Dr. Winchell, that actually it's heading in the right direction, that we all try to seek to standardize certain treatments, because I can tell you that we have started a pilot project in Lebanon where we actually focus on doing reconstructive surgery on those cases coming from Syria and displaced, which actually didn't have the proper trauma treatment which would have been required. And as you know, the reconstructive part is extremely financial intensive and time intensive, and prevention, as we mentioned several times, would be the better case. So when I'm listening what the WHO is trying to accomplish, and when I'm listening what you are trying to accomplish, then I think we are working together with very strong partners like the ICRC, the International Committee of the Red Cross, and I think when I'm listening, we should actually fuse our efforts and not duplicate our efforts, although we are actually more focused on armed conflicts, but we are still in these low and middle income countries. And I think this consortium of University of Global Health is actually an excellent platform exactly to establish these connections.
No, I just wanted to comment on the last comment and question. I think that global learning environment, it's not only learning environment for the bilateral, mutually beneficial learning, but also a place where the continuity of care, the data collection, the quality checks, are we doing the right thing? If you go now and look at quality standards, we really don't know what kind of outcomes are out there. So there is all that needs to be incorporated, and I think this kind of environments, this kind of collaborative environments will allow us to measure also what we do. And I think at some point that has to become a standard, and I think we have to be, as surgeons in general, we measure our results. And I don't see those results being measured in this kind of a global environment. So, as you said, the standardization can also lead to understanding what kind of quality we deliver, measure it, and then improve it. And so I think it's great to have this kind of collaborative environments where we can share information as well and improve care.
Is there somebody on the panel that wants to address the first question about post-injury care and rehabilitation?
Well, so no, I think Dr. Noriako's, Fiamma Noriako's question is really a difficult one because, the weakest link is even getting the patient to the care. And so just, I think from what I see, we are way ahead in terms of thinking about the aftercare. But if I saw on Dr. Winchell's slides, actually, that needs to be part of the standard, but I don't think the workforce is really there. At least in our conversation with our group and with the consortium we have been trying to work through, this initial conversation about the throughput of the patients through rehab did come up, but we really don't have any infrastructure on the ground to support those patients. So I think it's a great point, and this is going to require some additional advocacy and involvement of the policymakers.
So I would just say we should be very clear that the original focus of our panel was timely care for the injured, and so it was timely, and we focused on the more time-sensitive aspects and the care as opposed to the preventive. But that in no way represents where the center of gravity of the system should be, nor where the center of gravity of WHO's efforts are, which really lie in prevention, but there's an extensive program in rehab, which is not very, thankfully, is in my same department, and so we work together a lot. Among those efforts really recently, there is in the World Bank Disease Control Priorities chapter, in the same volume 9 where we have the emergency care chapter, there's a rehabilitation chapter that maps services to each level of the system and makes it really clear that even at lower levels of the system, there are effective and efficient rehabilitation interventions that can be implemented at very low cost. The other thing is there's a volume on rehabilitation and assistive devices in conflict and post-conflict settings. And then relative to I think we need to think of rehabilitation as a platform that maximizes your investment in emergency and surgical care, because you get much, 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 much less for each dollar that you put into emergency and surgical care if it is not complemented by rehabilitative services amongst those who do not die. So one of the problems is the way that data on mortality influences what we think of as priority interventions. So once you look at non-fatal injuries, it becomes very clear how critical and effective and cost-effective the rehabilitation interventions are. The other thing is relative to conflict settings versus everyday ordinary systems. There's a reason why our main products, both the basic emergency care course and the triage tool, are joint products with ICRC. And in the case of the triage tool, developed also with MSF. And the everyday system that addresses your everyday injury is also the necessary substrate for your emergency response. And so more and more, we are integrating this around an idea of resilience. Otherwise, what you see is the everyday system collapses, and you get much more mortality from your everyday conditions like pneumonia and malaria than you do from the earthquake. So we really, again, it's the same message, I would say, about integrating our advocacy and understanding the relationship between these platforms. It's not that they're all the same. You'll notice we've kind of stratified along the chain of care here, and that happens. We couldn't even coordinate the 2 pre-sessions on the same day. There was one on emergency and one on surgery. We're failing sometimes at this integration, but we're getting better. We need to be clear about what is overlap and what is a distinct set of skills that belongs to a distinct environment. And both of these things are very, very important.
Keep looking at Dr. Martin there. So we will integrate both of these sessions next year at CUGH 2020. So I want to thank our panelists, and I want to thank the members of the audience for being here. I think that this exemplifies us being better together and what the real spirit of CUGH and our organizations are. So I would like to give all of the panelists a big round of applause. Thank you.